Begin with a broad question to each of you. In part, what precipitated this hearing was the reporting from the Wallstreet Journal that highlighted troubling examples of veteran medication experiences. From each of your perspectives, how closely do those cases align with what your office or organization is seeing, and where do they differ? In other words, tell me whether what you see is what is reported in that article and what we should know about that. Start with you, Ms. Hundrup.
Thank you. So in our work, we had found there's a number of factors that influence providers' decisions to prescribe. They ranged from the resources at a medical center to complexity of the conditions, the comfort level with prescribing, as well as the availability and the types of treatment. So there's really a lot that can influence it. At the time, we did find there was, at the time of our work, which was based on fiscal year 2018 data, so it's a little bit dated, there were 37% of veterans with one mental health condition that were prescribed a psychiatric medication, either alone or in combination with therapy. And focusing on even more, those with PTSD taking medications, of those taking medications, where polypharmacy comes in, them taking 2 or more classes ranged from 32% from a primary care provider to upwards of 61%. Now, as has been stated, polypharmacy in and of itself isn't necessarily problematic. So in preparation for this hearing, we were looking to see if there was updated data on where the VA is in terms of just polypharmacy. Again, not to say that that alone is bad. It does increase risks. That was not available, so I would encourage the VA to make those data available, and it is worth examination. What we did recommend is making sure the treatment plans have clear, identifiable information so that they can monitor that and see where there are risks and mitigate those risks, such as if a provider is doing a lot of prescribing and you see a lot happening, you can look into that and see if that is appropriate to make sure that they're mitigating any risks or taking action if that may be the case.
Is that a suggestion so that we could compare what takes place at the VA with other healthcare providers?
Well, just to have a number of, to update where we were, a lot has changed since 2018. So just to understand veterans, for example, with PTSD or other mental health conditions, what kinds of prescribing, what kinds of classes of medications, psychiatric medications are they getting? Is there, for a while, there was a lot of concern about opioids in combination with benzodiazepines. I know that had been reduced greatly, and that was something that the VA made great strides in. But where are we today? Has that continued to decrease? I think some of these allegations in the article, we just don't have the data, so we don't know. So I think the first order of business is really seeing
Fresh
updated data.
Okay, thank you. Doctor, anything to add or suggest?
Yeah, I was actually quite disappointed in the article. I think it is devastating to read about the patient experiences. Those are real. Oh. It is. How about now?
Yes.
Yeah, I found the article disappointing. The cases were devastating. The patient experiences are real. But what I didn't and I wouldn't expect to have is what the medical records show, what the provider and healthcare team, what their response would have been and how they supported the patient. These were complicated patients. It's easy to understand that from reading the article. And VA treats very complicated patients. I was also very disappointed that the suggestion is that the VA providers are handing out medications to avoid providing adequate care. That's not what we've seen. We've been in every facility, CBOC, vet center, CLC. This is not what we're seeing. We are seeing compassionate, dedicated providers managing incredibly complicated patients.
Great to hear. Thank you. Ms. Fletcher. Dr. Fletcher.
Yes, thank you for the opportunity. So what we hear from the warriors we serve is that they often encounter medication recommendations before therapy is offered or even accessible. And so we know this doesn't happen everywhere, but we've heard it consistently enough that it suggests an opportunity to increase access to first-line psychotherapies and more shared decision-making in the treatment planning process.
Is what you're saying different than what Dr. Kovarik was saying?
No, I think there's a lot of similarities.
Similarities.
A lot of similarities, yes.
Okay.